to attend the Health and Wellbeing Board meeting on Thursday the 10th of March 2022. Now, I've been made aware there is a road traffic accident on the A1 which has affected attendance here, it would seem. So we just hope that the emergency services deal with that issue as best they can. I'll go straight into the agenda. Apologies for absence.
Apologies from Julie Boyack, Jane Lothian, Paula Mead and Rick O'Farrell. Thank you very much.
I'll go into minutes of the previous meeting. Minutes of the meeting of the Health and Wellbeing Board held on Thursday the 10th of February 2022 as circulated to be confirmed as a true record. Can I confirm that's a true record? Yes, agreed, thank you. Item 3, disclosure of interests. Does anyone have any interest to declare? No, it would appear not. So I'll go straight into item 4, which is the update on the epidemiology of COVID-19, the Northumberland COVID-19 Outbreak Prevention and Control Plan and the Vaccination Program. And I'll go over to Liz Morgan.
Thank you very much. So this is the dashboard, or the most recent version of the dashboard. It is becoming increasingly difficult to interpret the case data because of the changes in testing guidance and testing behaviour. So what we are seeing is that testing rates have dropped off significantly, and that's a lot of that will be due to the testing in schools, which has now ceased. But what we are seeing locally, regionally and nationally is an increase in case rates, and that's probably down to a BA2 subvariant. So this is a sort of like son of Omicron, and the evidence is that that is does have some transmission advantage. So while we're seeing the original Omicron variant starting to fall away, we're starting to see increasing numbers of this BA2 variant. No evidence yet of any impact on severity, so no evidence that it's more severe or less severe than the Omicron variant, and also no evidence that it has any impact on vaccine effectiveness. Testing will cease at the end of this month, so routine asymptomatic and symptomatic testing will come to an end of this at the end of this month. So we may continue with elements of this dashboard, but we're probably going to withdraw this particular view of it. So in terms of what's changed since the last meeting, well, obviously quite a bit. So we had the announcement on the 21st of February on how the government is going to or how the government proposes that we live with COVID. So much of the national response is now being scaled back. So contact tracing, mandatory self-isolation and support, testing in schools, but actually not special schools, alternative providers or schools, ordinary schools that have got SEND provision, will still continue to do testing in those, or still doing testing in those elements. Changes to statutory sick pay, which will take place on the 24th, and as I've said, most of that free symptomatic and asymptomatic testing will come to an end for the vast majority, and actually all of the local testing sites, the mobile testing units and the regional testing units will cease to function at the end of this month, and they will all be demobilised over the next 9 months. The important thing, I think, though, is that just because the mandatory requirements have gone away, it doesn't mean that there isn't still a requirement to, or a need to, self-isolate and test while testing is still available. The best source of data we've got on coronavirus at the moment is through the ONS survey, and that survey tests tens of thousands of people every week across the country. It is our most reliable source of information on the prevalence of infection, and the most recent data shows that about 1 in 30 people, had they been tested, would have tested positive, and that's down from 1 in 25 in the previous week. There's quite a lot of regional variation, so it is lower in the northeast, but I think what it tells us is there is still a lot of COVID about, and just to emphasise that, you know, it's not a mild infection, it's just less severe in people with good immunity. So, living with COVID, which is the COVID-19 response, or the spring plan, as I said, was published on the 21st of February, and it's got 4 main pillars. So the first one is around really increasing emphasis on guidance and individual responsibility. And this reflects a sort of a shift in approach, really, to managing COVID in the same way as we do other infectious diseases, just using basic public health interventions. The second priority is around protecting the vulnerable, and there are pathways in place for some individuals at increased clinical risk to be able to access antivirals after a positive test, and those individuals should all have been sent a letter explaining what that pathway is, and they should all have been sent PCR tests so that they can test if they develop symptoms. The third pillar is around surge testing and vaccination, and our ability to respond if we see a variant of concern which is resulting in an increase in cases. So we also need to have a robust surveillance system to allow us to identify those variants of concern. And the fourth pillar is about really building on the research and innovation which has come out of COVID-19 to support the COVID-19 response going forwards. So what we have agreed locally is that we will revert back to the health protection arrangements that we had in place before the pandemic. So, and those arrangements were that the regional health protection team led on all outbreaks. We do have a group of residents who are at higher risk from severe illness, or who have less confidence in returning to everyday activities, and I think we really need to find a way to ensure that those individuals are supported to understand, manage and mitigate the risks, because unless we do that, we're not going to enable them to live as near a normal life as possible. I think one of the other opportunities for us is around the IPC skills and capacity that we've built up in care homes, and that focus on infection prevention and control really needs to be maintained and reinforced across society. So that will enable us to better support the whole spectrum of infectious disease, which has broader health, social and economic benefits. And then I think the third opportunity for us is around recognising that families on low income and in jobs that have conditions which are not quite so good, so 0 hours contracts, for instance, you know, those families continue to be disadvantaged by COVID, because actually they can't afford not to work if they or their children have symptoms. And what we've escalated through the normal routes is an opportunity to review statutory sick pay as part of this all hazards approach to the management of COVID. So just a little bit about the vaccination programme, giving Richard the day off. So the vaccination programme is still performing really well. We're still getting a trickle of people through to have their first doses, slightly more people through to have their second doses, and still getting people through to have boosters. So, you know, we are still picking up people who haven't been vaccinated to date. I think in terms of the future of the vaccination programme, there are a number of priorities for us. So there's this evergreen offer for first, second doses and booster. We're anticipating some sort of autumn booster subject to confirmation by JCVI. So that could be cohorts 1 to 6, or it could be cohorts 1 to 9. And we're in the process of developing contingency plans to surge vaccination in response to any increase or potential increase in cases. There's still very much an ongoing focus on accessibility and inequalities, and I think what this programme has highlighted is the variation in uptake, both to this actually and also to other vaccines. Also something in here about just taking every opportunity to align the COVID vaccination programme in the future with other vaccination programmes, because we really need to maximise the capacity that we've got within the system. And then in the sort of planning document that came out, there was a very clear role for local authorities to support the delivery of the vaccination programme moving forward. So we're working very closely with the CCG and the regional SFOP to make sure that those plans are comprehensive and complete. So the offer has been extended to all 5 to 11-year-olds, healthy 5 to 11-year-olds, and I think that's starting in April. We've got a spring booster, which is aimed at over 75s, care home residents and people who are immunosuppressed over the age of 12, and very much a continued focus on community engagement too, because there are still people out there who don't have the level of confidence needed to take up the offer. So we're still promoting those messages. And then, as I said, planning for contingency. So we need to plan in case we need a surge. And that planning is based on a 2-week time frame to surge to required capacity. So in doing that, we're sort of really building on what works in our programme to date. So using every asset that we've got available, so primary care networks, community pharmacies, pop-ups, roving models, extending opening hours, and as I said, that North East and is part of a bigger North East and North Cumbria plan, which is in development. So just finally then, the reason why we can shift our approach to one which is very much focused on COVID to one which is more of an all hazards approach is entirely down to the vaccination programme. So that continues to be, absolutely pivotal to success, and we really need to maintain good levels of immunity. We need to normalise all of those behaviours which prevent infection, because actually everything that prevents transmission of COVID also prevents transmission of a whole range of other infectious respiratory and actually non-respiratory illness. We need to use what we've learned to support people to stay at home if they've got significant illness. We do have a culture of presenteeism in the UK, and actually that has a bigger economic impact than absenteeism. So we really need to change our culture to support people to stay at home if they're unwell. As I've said, there are a number of people in our communities who continue to be disproportionately affected, and we need to keep pushing at changing our sickness benefits processes to enable those people to stay at home. And then, communication continues to be absolutely crucial. We need to make sure that we're giving out simple and very consistent messages that people can understand. So that's all from me around COVID. We're really waiting for further guidance to come out on the 24th of March, which will focus on a whole range of settings, workplaces, care homes, new IPC guidance, use of personal protective equipment, etc. So at the next meeting, I'll be able to give you an update on where we are with that, and hopefully a new testing strategy as well. Thank you.
Okay, does anyone have any questions regarding that?
Sorry.
I can't see any hands. I think we've discussed it so often. I think most of our questions have been answered at one point or another. So what I'll do is I'll go on to the next item, which is the Director of Public Health Annual Report. I've got 2020 from Liz again.
Great, thank you very much. So this report is quite old now, actually, because it came out, I think, probably last September, October time. So as you'll be aware, Directors of Public Health have got a statutory duty to write an annual public health report on the health of the population, and not surprisingly, the focus of this particular report, which is probably going to cover 2 years actually, was developed through during the fourth wave of coronavirus in July 2021. And it really reflects the situation up to that point, and it's in the form of a video, which hopefully you've got the link and have had an opportunity to look at it. So the focus of the report was really around inequalities, because we all know that the same pandemic is being experienced very differently by different sectors of the community. So there are differences in mortality, people from BAME backgrounds, people with a disability, those in the most deprived areas have experienced higher mortality rates. And actually, it's not just the direct effects that have been experienced unequally, it's also the indirect effects. So things like loss of employment have been greater in younger people. Some children will have found it really difficult to study from home. Health and social care staff are at increased risk of adverse mental health outcomes. So it's not just the virus itself, it's the way that we've dealt with the pandemic, which has had a much broader impact on the economic and social fabric of society. But there are a lot of mitigation measures which have been put in place, which we've highlighted in the videos, which actually have had a really positive impact on our communities. So the report also makes some recommendations on what more we can do to address the increasing inequalities attributable to events over the last couple of years. So the report's in a series of videos, and we have focused less on healthcare and more on the wider determinants of health. So the first video is just an introduction and overview. The second video really focuses on income, job security, social isolation and mental health. The third one focuses on how the wider determinants have shaped experience, so how, particularly around poor housing, so it's looked at health behaviours, evidence from Balance, our regional alcohol programme, that alcohol consumption has been polarised even further. So heavy drinking has increased in those who were already heavy drinkers, and of course those people live in our most deprived communities. The fourth video talks about the groups that have been disproportionately affected by the pandemic. So it talks about those areas with high levels of deprivation, people from a BAME background, people with learning disabilities, older people with long-term conditions, people with pre-existing mental health conditions, and people at risk of domestic or family abuse. And there are also some less obvious groups as well, so health and social care workers, children, unpaid carers. And then the fifth video talks about our response as a council around employment, wellbeing, the role of Northumberland Communities Together, digital access that we've promoted through libraries, ramping up support for homelessness, etc., etc. And then it concludes with just a set of 4 recommendations. So looking at what outcomes have been affected, how can we minimise or prevent those negative experiences? We already do a series of sort of equality assessments and carbon reduction assessments on policies and programmes, but actually the suggestion is that this needs to include an inequalities assessment, and what we're intending to do is to develop that as an integrated approach, but we might need to do that incrementally. The third recommendation is around community resilience, because community resilience is absolutely critical to our ability to sort of survive events like this. But we won't have resilient communities if parts of those communities are left behind. So we need to work with our communities, focus on those experiencing inequalities so that the whole community is more resilient and better able to cope with future challenges. And then the fourth recommendation is around supporting our own economy through shopping local, through supporting local businesses, local skills development, and trying to get the most out of the Northumberland pound. So that was it in a nutshell. Very happy to take any questions if anybody has any.
Councillor Glenn Sanderson.
Thank you very much. I have to say I'm slightly disappointed that there is no mention in here of the joined up approach of the local authorities working together for 14 months, casting aside political differences and working for the benefit of all residents, and how we acknowledge that. There doesn't seem to be any mention anywhere of membership or democracy. Secondly, I think the council worked very well as a unit here, ensuring that our local members were aware of things that were going on a weekly basis by a briefing, and the good joined up work that we did with officers and members together. Now, it would have been nice to have seen a mention of that somewhere. Is there anything in the, because maybe the NHS, or whoever wrote this report, Public Health England, had no idea about this. If not, why didn't they know how well we'd worked together? That's the first question, if possible, please.
Well, the report is my report, so I'm sorry if I didn't put anything in there specifically about the work of the LA7 and the way that we have worked across local authorities. I think you make a very good point, but it was about trying to highlight the impact that the pandemic had on our communities and about our response as a council over the last 2 years.
Okay, so I think that's I hear what you say. I want to make it very clear for the minutes, though, that there was an extremely valuable joint council, cross-council working together during that time that made a huge difference, in my opinion, and many other people's opinions. Perhaps you don't share that opinion, I don't know, but it made a huge difference as far as I'm concerned in the way that we ensured that our population were cared for, and that the working of this council between members and officers and keeping local members involved on a weekly basis was very valuable as well. So I do regret that it's not mentioned in here, but perhaps that's because we didn't discuss this in its form when it was being formulated. We probably haven't made enough of what I think was a really important piece of joint working, so that when there is a crisis like this, it does show that local communities, local government can work really well together, and I just do regret it a bit that it's not in here.
Okay, we'll note that, Councillor Sanderson. Jeff Watson.
There's the definition of poor housing. I'm trying to think of what the council can do about that, but is poor housing mainly in the non-council rental section? Because if the quality of the house that people are in one of our houses, they should be of a good quality, and if they're not, we should be complaining to our housing staff to make sure they are. So, is that what does poor housing mean?
So there is a sort of standard for, there is a quality standard for housing, and obviously for our own housing, so the housing that we have a responsibility for, that we provide as social housing, we make every effort to make sure that housing complies with that standard. And we've got very good pathways in place to ensure that if people are having problems with their housing, that we can, we've got an ongoing programme of routine maintenance, for instance, and repairs for that social housing. I think Some of the problem that we're experiencing is in the private rented sector, where there isn't as much control over the quality of the housing, and as a local authority, sometimes our the sort of tools that we've got to address that can be quite limited, and it can take quite a long time to sort out those sorts of problems. I think there was a report that went to either the last scrutiny or the one before about housing, and actually it takes quite a long time to go through the legal processes that we've got to try and address some of those issues. But I think there are other issues there are other initiatives that we can employ. So there's something called a selective licensing scheme, which has been used in some other local authority areas, and we're looking at whether we can introduce it into an area in Northumberland which is effective at improving the quality of housing. And of course, improving the quality of housing has a massive impact on other things as well, like antisocial behaviour. It improves community cohesion, and improves health and wellbeing across the piece. So there are huge advantages in improving the quality of housing.
Thank you. Liz, the report emphasises the lessons which can be learned. I beg your pardon, sorry. Liz, the report emphasises the lessons which are going to be learned from COVID, particularly in terms of inequalities. So 2 questions from that, if I may. One, will this be going forward to the summit on inequalities, which is being held in a couple of weeks' time? And the second question is, in terms of lessons learned, I recall way back in November, I think it was, Dr. Catherine Bush made a presentation on deaths in Northumberland from COVID. And I think at the time there was a suggestion that somebody might look at that report, see what we can learn, and then develop actions for the future. Did anything happen to that in terms of lessons learned and actions from Dr. Bush's report?
So on your first question about the Inequalities Summit, we're not going to talk about this report specifically, but obviously it is very much focused on inequalities and what we can collectively do as a Northumberland system to address those inequalities. And of course, what the pandemic has highlighted is, it's just exacerbated those inequalities that already existed in our communities. In terms of the report that Catherine did, we've had a couple of meetings this week actually to look at excess death data. And what we really want to do is to drill down into that data to find out where the issues are. So, are there particular issues around cardiovascular disease or stroke or infectious disease? So we're just starting to do that bit of work at the moment, going back to the primary data, which is in the primary care mortality database.
Okay, thank you.
Okay, any more?
Yeah,
Councillor
can
Sanderson?
I just ask then, what is going to happen to this document now?
2 recommendations which are to comment on whether we accept and support recommendations. Is there a follow through from that, I presume? If we accept it, I guess we'll be looking and reviewing, would we?
Yeah, so the obviously I've put 4 recommendations in this report, and so the intention is that the public health team will follow up on those recommendations.
So you see, in a way, this is one of the issues that I've got about public health and the council, because it shows that we're not, sometimes we work really well together and everybody does a fantastic job. This is an example really where I think that we could have done with a little bit more discussion, again, about how councils can work together well with the public health side of things. And I explained before how I feel that the democratic part of councils work well together. And I do regret, in a way, I'm afraid, that there is no mention at all in here of that. I know Councillor Wendy Patterson is involved. So is this going to Cabinet then? Or where does it go now?
It's already been to Cabinet. It's already been to informal Cabinet.
Informal Cabinet.
Normally the annual health reports come to scrutiny and the Health and Wellbeing Board.
Right. Was this report taken as an agenda item at informal cabinet, or was it just in your report? I can't remember, I'm sorry.
So it was, this report would have gone to informal cabinet, yes.
Right.
Like all health and wellbeing and scrutiny reports.
Yeah, okay. So where does it go now then, please, Liz?
Well, it doesn't go anyway. It's for me to pick up on the recommendations and make
Right.
sure that they are taken forward.
Right.
There we are. Right. I think you make some very good points about what do we do with a piece of work now that makes it real and takes the thread of the intent that Liz has written about, and how do we do it. So thinking about the Health Inequalities Summit that's coming up, there is a data pack which will be going out, and some of the information which Liz has taken into account in her report about inequalities around Northumberland will be used to focus the minds of the people at that summit that inequalities exist and that we have some understanding of them. The public health team will be at that meeting, but also we're going to have much wider representation, which I know you've ensured. And then I think that then brings into account the next bit of our discussion, or one of the bits of discussion today, about how we as a Northumberland place operationalise these concerns, these aims between all the partners in Northumberland to try and address some of these. And that comes down to, do we have the governance arrangements and a system board that works with health commissioning and how we focus that, but also how do we align the intent of Northumberland County Council and all of the other agents, the voluntary sector, just as important in this, how do we engage our communities? And it is a huge piece of work, but the thread of this needs to be one part that runs through it all. And it's about bringing it all together and making sure that committees such as this then say, okay, so our system board, which will exist, go away and make sure the officers of our organisations have a work plan that takes into account what we think is important. And I think we're at the early stages of that. I think we're coming out of a pandemic. We're operating in a very different environment to how we have done before, I think. But we should have these aims and aspirations that run through all our organisations. So I agree with your points.
Yes, Health and Wellbeing Board is to get together public health and the council, isn't it? To work together and see how we can best help each other, and where good practice has taken place to acknowledge that and learn from that. So anyway, I've had my say. Absolutely fine with it, but I just perhaps might think that we could. I mean, would it work, Liz, if you brought a provisional, a draft version of this to the next Health and Wellbeing Board in a year's time, and we could then have some input into your report, which you could either ignore, absolutely, or might be valuable?
And obviously since then it has been published. So I think the timing this year has just been a bit awkward.
Everything, but it would be really good if, but because I said in another meeting this morning, I do sometimes think that we get reports given to us at this meeting, which we sit and listen to and then agree. It would be nice to have a kind of some input into, into formulating a final report via the Health and Wellbeing Board. That's all I'm suggesting for you to think about.
Yep, absolutely. Thank you.
Thank you.
Okay, have I got anyone else who wish to comment at all? I can't see that, so I'm going to move to the recommendations. I've got, well, first a comment. I think we've commented, particularly Councillor Sanderson's commented on that, and it was to accept and support recommendations. Do we accept and support those? Yes, I think we do. Okay, thank you very much for that item. I go to the next item on the agenda, which is Northumberland Suicide Prevention Strategy 2021 to 25. I've got Pam Lee is presenting on this. Thank you, Pam.
Thank you. Thank you, Chair. For those of you in the room who don't know me, I'm Pam Lee. I'm one of the public health consultants in Liz's team in the council. So I've come today to talk to you about our suicide prevention strategy. In your documents, you have an extract from the Joint Strategic Needs Assessment, which is obviously on a hard copy, and the JSNA is actually a web-based system. So what you're seeing here is what you will be able to see on the website. This is a really good example of how it's a very short narrative so that people can read this and they can then go through links to the updated data, which means that people are seeing the exact data at the time that they need to use it. I just want to highlight a couple of things in this part of the paperwork. One is that you will notice that our numbers of suicides in Northumberland are low, which is really good, and I'm very happy about that. However, our rate of suicide is actually higher than our regional average and our national average. So what happens with suicide is, because the numbers are low, just 1 or 2 incidences can actually change our trends and it can change our data. So today, I don't want to kind of get too involved in that data set because that changes very quickly. But I do want people to be aware that the strategy is based on the evidence and the data from the JSNA. Before I start to talk about the strategy, I just want to say that instead of me just sitting here and talking you through a report that you've already seen, it's probably more helpful to you to interrupt and ask questions or make comments, so that if I'm telling you something you already know, I can just move on. But if I'm talking about something that you really want to talk about, something that you find interesting, or you have specific questions, I'm very happy to have the conversation about it. If that's okay with you, Chair, if that's all right to run it that way. Okay. So, going through the strategy, we've got the executive report, the executive summary at the start. The executive summary takes into account where we are in terms of our data. It also takes into account the effect of COVID. Now, COVID, as Liz has already talked about extensively this morning, COVID is something that will be with us for a very long time. And in terms of suicide and in terms of mental health issues from COVID, we can't say it's over, and we can't say that we can do anything about this with the vaccination program. The effects of the psychological effects of COVID will be with us for perhaps 10 years, perhaps 20 years. One of the things about suicide during COVID is that it would appear that the data show that we've actually had a reduction nationally in suicides. I think that can be a bit of a false story, because we have had great delays in the system and in the coroner's system, which means that suicides haven't necessarily been confirmed during that period. So what we may see over the next couple of years, as the coroner's system actually kind of catches up and picks up, what we might see is an increase in numbers that we wouldn't expect, and then we will see a levelling off. But what we don't know is the impact in terms of something that has happened now during the COVID pandemic, what impact that will have, and we will see that playing out over the next 5, 10, 15 years. So I think that's really important to bear in mind. And I think that when we talk about this, it's important that us, as a Health and Wellbeing Board and as a system, so all parts of the Council, because everything impacts on suicide, and suicide impacts on everything, and I think it's important that we all have that same story. And if anybody has any queries about it, if anybody gets questions or queries and they don't know those answers, then I'm very happy for people to contact us, because I think it's really important that we do have a consistent message about this. We then talk about our priorities, and the reason we've identified those priorities is because we know that some people are at higher risk of suicide than others. We talk an awful lot about everything that we do, we talk about an inequalities focus. What we say with suicide is that suicide actually goes across the whole range of people. So it doesn't necessarily follow that people who are suffering deprivation have a higher suicide rate than people who are more affluent. And I think that's really important. This suicide report only talks about what we would call a completed suicide. What we do see is a lot of self-harm in people who have suffered more deprivation. But in terms of completed suicides, it is actually the same across the whole spectrum. So this report then takes you through the progress that we've made over 2021 to since 2019 up to 2021, and it takes us forward up to 2025. The reason that it goes back and forwards, and the reason that I've called it a progress report, is because the evidence that we have around suicide doesn't change. So it's not like saying that one day something new will happen and we'll stop doing what we've been doing and we'll start doing something different. And that's why it's got kind of a longer term aspect to this than other reports that we bring to you. What you will see is that it's a multi-agency approach, and I'm sorry that Councillor Sanderson's just had to leave, because I think this does actually show how well we work together across the whole of the system. So we work very closely with the CCG, we work very closely with the safeguarding teams in both adults and children, we work very closely with our mental health trust for obvious reasons, but we also have the voluntary sector represented on these groups, and the voluntary sector is very, very important to us. They can often respond more quickly to things than we can, and they can often identify issues in a community that we can respond to before we actually get somebody in crisis and somebody taking their own life. We have appointed Catherine Seymour as our elected member champion. Catherine is our champion for all of mental health, not just suicide, but it is really good to have that kind of champion and that person who can think about all of the other policies and bring kind of an elected member's view to the work that we do. I don't want to go into the detail of the data, as I said, because the data changes so quickly. But I think that it's really important that as members and as members of the Health and Wellbeing Board, you see that we build on the assets that we have. So we have listed the services that we commission currently, whether it's we commission them or the CCG commission them, or if they're statutory services or voluntary services. And we've identified all of those because they have an equal and important role to play in this. We then go into defining suicide, and I think, again, that is really important that we understand what it is that we're talking about here, because it's a very emotive subject and it does affect everybody, and I think we all have to be very clear about where we're coming from in terms of our understanding. So there's quite a lot of information in the report to help people to understand that, and there's information to help people understand our high-risk groups, because even though I've said that it is across the whole of the spectrum, there are still some occupations and there are still some groups who are at higher risk of suicide than other places. I think the economic risk of suicide can't be underestimated. There is a clear link between unemployment and suicide, and we have to be careful about that. We have to think about that when we're talking, especially when we come to the Inequalities Summit in a couple of weeks' time. We need to be thinking about all of those policies and everything that we do and what positive impact it can have on people's mental health. So it's not just about having jobs, it's about having good quality jobs and jobs that have support built in and around them. And I think that when we're talking about inequality and the wider determinants of health, we need to be very clear about that. We need to be very clear about how we approach the media with suicide, and we need to be able to tackle what I would call poor reporting about suicides, because what we do know is that suicide can actually have a contagious effect, and especially with social media, we need to be very careful about how that is being delivered. We talk about the age and sex breakdown, we talk about the impact of mental ill health. We also look at substance misuse, so things like alcohol, which again Liz has mentioned in her DPH report. We need to think about the impact that alcohol and substance misuse has on suicides. Over the coming year, one of the things that we will be looking at more closely is social isolation and loneliness. We've always known about social isolation and loneliness, but I do think that what COVID has done is actually has emphasised that and has brought it into a spotlight in a way that it hasn't been before. So we will be working with other parts of the county to think about how we can improve that and reduce the number of people who we have who are living with that. We also have an issue around veterans, so people will be aware of that. We know that people who have served in the armed forces are at higher risk of suicide, and we also know that those who are in contact with the criminal justice system are also at higher risk of suicide. And obviously we have our prison in Northumberland, so we work very closely with the prison to make sure that we're all working together and we're supporting them where appropriate. There is a section in here that talks about British Transport Police and Network Rail, and since this report has been written, Network Rail have actually been in touch with us because we have triggered their point for doing more work. So how they look at it is how many incidents they've had on the line, but they look at it to the nearest station. So what has happened over the past 12 months is that they've had 3 incidences which have triggered a response from the Cramlington station. As it happens, some of them are actually North Tyneside residents because the line obviously goes south of Cramlington. But the impact that it has coming up from Cramlington and all the way up of that east coast. Some people will be aware that there's a plan to reopen some of the disused lines around Blythe and Ashington, which I think personally is a really good thing. I think it's a good thing for our employment prospects apart from anything else. But what we have talked to Network Rail about is actually kind of designing out trespass and suicide so that when they're looking at reopening those stations, they're looking and making sure that those stations are not easy for people to trespass and taking away the means of committing suicide, because that is a really big issue. We've also gone on to look at kind of the prevention, if you like, of suicide in terms of upstream work. So we do an awful lot of work around good mental health promotion and prevention and support. And a lot of that is done in our schools, so that we actually have whole school approaches, and people will be aware again of the impact of COVID on young people's mental health. So what we're doing here is trying to improve young people's mental health so that it doesn't lead to those people to be coming into crisis. We have a whole range of online sites, and we have a whole range of things that are going on, including our health trainers and other people who we train for suicide awareness, so that they can have those conversations if they identify somebody who they think is at risk. I don't really want to talk any more about it because I think it's probably laid out reasonably, well, I hope reasonably well, and for people to understand what's going on. But I'm very happy to take comments and questions from anybody.
Okay, does anyone have any comments? Councillor Jeff Watson.
First one's just a comment. I'm absolutely gobsmacked to see that suicides cost us a terrible amount of money. It's an awful thing, but 150 million over 2 years seems like an incredible amount of money in Northumberland. The other one, more of a point really to our medical people. If we know people are suicidal, then we can treat them. But my very, very limited experience of people who I know who have committed suicide, I don't think there was any forewarning. And I wonder, have I just got the wrong end of the stick? Or do the medical practitioners generally are not surprised if somebody does it, if you know what I mean? Probably Richard would be a good person to answer that.
Thank you. Thanks for the report. It's incredibly emotive, isn't it? And I personally find it incredibly difficult to think how awful it must feel to put somebody in that situation and the impact it has on families. And in my mind, there's 2 elements to this. One of them is that, are our services trained and sensitive to individuals and their risk, and how reactive can we be to make a difference for an individual? And and often in the analysis of a suicide, we look for opportunities missed and try and learn from them, and then we look at what services are being provided and can we do something about that. I'm very interested to hear about this kind of much more generalised approach to how the system can work to reduce the opportunity for suicide, because I think that comes back to your point, you know, and then we have the specific people who have got more access to the means to do it. So I think approaching it from both angles is a must, and trying to understand how we can intervene in those individuals. Sometimes it's about giving people permission to say how bad they feel and so these people have often had contact with people, but the person didn't realise the current situation. I hope that helps.
So, do you have many people where you've got absolutely no warning, it just happens?
I think sorry.
I'll come back one second. I think this is such an infrequent thing that it's very difficult to comment about specific individuals, I would say. So it's very hard. Okay.
That's exactly what I was going to say. The numbers, thankfully, are so low, and we have both ends of the spectrum. We see people who attempt suicide on a number of occasions and then complete suicide. And we also see people who, almost out of the blue, you know, and nobody has any warning. But I think it's really important that people understand that, because picking up on Graham's point about, you know, those people will have been living with families, colleagues, friends, whatever, and the guilt that can be caused from that. So we have to be explaining to people that actually some people will want to take their own lives regardless of what everybody else does. I think this lady.
Wendy Patterson, and then I've got me to...
Thank you very much, Chair. Is it Suzanne?
Pam.
Pam. Sorry, Pam. I missed the beginning of your presentation. Unfortunately, the A1s had an accident and again diverted again. This is very emotive, especially for me, because I was at a funeral on Tuesday for someone who did take their own life. I think sometimes life becomes too much. But am I right in thinking that the most well-known organisation, if you're in trouble, is still the Samaritans? The problem with the Samaritans is they just listen, don't they? I mean, they don't put anything forward or, I've got a concern here. They're really just to listen, aren't they?
Yes, they are, but they can signpost people to services. They don't refer people to services, but they can signpost people to services. And I think in terms of the work that they do, they are very highly regarded. And they do quite a lot of work in terms of promoting themselves, and they promote themselves at sites where people are at risk. You know, there are sometimes, I know this might sound strange, but sometimes there are sites where people actually go because it's known as a suicide spot. And so the Samaritans actually promote themselves and put signs up there about talking to people. And sometimes they have contact details, telephone so that people can make easy contact. So I think they are a very good organisation. Whether we could look to integrate them better into a wider system, I think is an interesting point. But I think they would probably want to maintain their independence and the role that they have. So I don't think it would be as easy as kind of bringing them into a referral mechanism.
That's interesting. But, I mean, thank you. This is, you know, very complex, and I'm sure this has taken a long time to put together. And it's never been more pertinent, I don't think.
I think that is very valid. Thank you.
Hi, I'm Pam Travers. I'm from Cumbria, Northumberland Town and Weir Mental Health Trust. We deal with individuals all the time who are distressed or depressed. I think there is a couple of things. One, I welcome the report, because sometimes to us it feels like we've still got a lot of suicides, because obviously we experience probably more contact than others. So it is good to see that it is not increasing, because I think we had a real fear that during the COVID experience it actually would increase because of loneliness and isolation. But we are still seeing, as you've rightly said, the outcomes of COVID on lots of individuals and the impact that that's had. And the anxiety people feel about the changes now. So it's not just about where we were, it's what actually people are feeling now about the prospects and the anxieties that they've got about society opening up. I think we do, as you've listed, a number of places that we work very closely with different organisations, including court diversion, which I think is another area that's really a real good development, because there, as you say, a lot of people who are in the legal system also lean towards acts of suicide or attempts. But there is that whole society, that whole thing about just asking the question, how are you feeling, are you okay? And I think that probably will have more impact. And it's been just what you've seen in the media recently of some of the social media stars, should I call them, people in football talking about what it feels like to feel that you would want to take your life, I think is really impactful. And the more that we can continue to do around males and getting males to talk about how they're feeling, or letting you know that they're feeling like that, and not holding those secrets, is again something that I think, you know, we need to think about in the future about what we continue to do. So just that, I'm happy to talk on a one-to-one about anything else.
Sure, we can pick it up outside. We do have good representation from CNTW, but I'm very happy to pick it up with you, Pam.
Any more questions or? Yes.
Not so much a question, but just to say thank you very much for a very comprehensive report. The amount of breadth and depth which it covers is very assuring. It goes through the causes, preventative measures, and also an integrated approach. So I think, you know, whatever can be done within the county is being done. The only cautionary note is a lot of the factors which contribute towards an individual taking his or her own life, it's because of factors beyond what you can do, beyond what the county can do, because there's a national perspective here, and what happens at central government, you know, in terms of society, how it thrives, how it suffers, and so on. So I admire what you're doing, and I wish you well. But I think just a cautionary note: some of the contributory factors are beyond the county, actually.
Can I just come back on that? First of all, thank you very much for those comments. Secondly, just to go back about how this all links up together, the whole Inequality Summit that we're having in because it is about how we build that community resilience and also how we build that knowledge so that people can ask for help, but so that people can respond to it and know how to respond to it appropriately.
Thank you. Any more questions or comments? I just, I'm a local member in Cramlington West, which covers most of that railway line section. I'm aware of incidents over the years there. Is there anything more we can or should be doing there? I mean, it's going to be a changing landscape there because there's going to be so many houses built beside where the issues are there. But is there more we should or can be doing?
We've linked in with Network Rail. I still want to call them British Rail, but we've linked in with Network Rail, and we had a long meeting with them on just last Friday morning. They've done quite an extensive, in-depth research looking at the station and the line, and they're looking to see whether we can do things about maybe adopting the station because that station is currently unmanned, looking to see if we can almost improve the outlook of the station, because at the minute part of the station looks kind of a bit run down, and all of that contributes to how people feel. There's quite a lot of kind of open line, if you like, along that line, and we're going to work with British Transport Police to look at, first of all, securing that line, but also some of the feedback that we got from young people particularly was around the fact that it's quite a, if I say nice place or a good place to go for young people to go and drink and take drugs. So there's all of that work that we need to be doing about, you know, alcohol sales, access to drugs, and making sure that those places aren't easily available and that they are supervised. So actually, we're working very closely with Network Rail on that. But if there is anything that we can do, I'll certainly come back to you.
I'm aware that both county councillors in Cramlington and the town council are very keen to see improvements at the station. There has been some planting. The bridge is actually out at the moment and is being refurbished. There are signs, but it's never looked the best, frankly, and it does need to look better. And I do think that would make an awful lot of difference, just psychologically, doesn't it? Really,
absolutely.
You know? I'm glad that that's something that's being talked about and is being acknowledged. Have we got any more? I think that's just done. So I've just got to say, do we approve the revised suicide strategy 21 to 25? Agreed. Thank you very much. It's a very informative report. I should go to the next item on the agenda, which is the Northumberland Cancer Strategy and Action Plan. I've got Dr. Robin Hudson. What might be you?
Yes, good morning. My name is Robin Hudson, Medical Director at Northumberland CCG. I'm going to be sharing this presentation with Graham Mathewson, who's the Operations Service Manager from Northumbria Healthcare Foundation Trust. Just before I start, I just wanted to, we've talked a lot about integration and collaboration, and I just wanted to emphasise that really for the last few years, the levels of collaboration have been very high in Northumberland. We have a local cancer locality strategy group, which was Northumberland based, and we last year joined that with North Tyneside to align our priorities and our thinking. And also we have a wider North ICP cancer group, which meets with the 3 hospital trusts at Newcastle, Northumbria and Gateshead, and the 4 CCGs and the Northern Cancer Alliance. So we have a regular forums where we can actually look at what is going on with cancer performance in not just in our county but in our region. Okay, I've lost that. Nope. There we go, sorry. In terms of overall cancer performance, what we have seen, particularly during the COVID pandemic, is a lot of volatility in terms of the performance that's happened in terms of managing individuals with cancer. Currently, the activity levels are now back to where they were before the pandemic. So on month-by-month basis, in terms of the activity and the number of referrals coming in, those levels have gone back to where they were before the pandemic. However, if you look over the 2 years of the pandemic, undoubtedly there has been a reduction in the number of expected referrals, and that is obviously an ongoing concern for all of us in terms of, are there individuals in our county who are still not being diagnosed with a cancer? And one area of particular focus will be lung cancer in that, but Graham might allude to that later on. In terms of performance by specialty, the 2 key areas we are focusing on at the moment are on dermatology and on breast cancer pathways. If you look at that table, you'll also notice children lower down on that top table. Just to reassure you, we did do a deep dive analysis to look at those figures. First, the figures are very small because actually cancers in children, whilst very important, are not common, they're rare. However, we did do a deep dive into those cases and found the majority of those were actually referred in, but they were not cancer. Okay, they were suspected cancer. But just to say we're not complacent about that, we do watch those figures as well. In terms of current areas of focus on the breast cancer pathway, I think the 2 key issues and pressures here has been, number 1 is the volumes of referrals have gone up very significantly. Now, it's complicated. We've got a breast screening program. We've also got the media and health education. You may be aware of the high-profile case of the Girls Aloud singer who died at the end of last year from breast cancer. And these things pique people's not interest, but they make people anxious about and maybe make them more self-aware, and therefore they present possibly earlier, which is a good thing happening out of a tragedy. But the other issue with the breast pathway has been diagnostic capacity in terms of radiology, and maybe Graham will be able to allude in a bit more detail on that in a few moments. Dermatology or skin cancer. Before the pandemic, I work as a GP. If I saw someone with a suspected melanoma or a cancerous mole, I would refer them on a 2-week pathway. And historically, the melanoma clinic was a very high volume, very fast clinic where large numbers of individuals would go through and be reassured or treated. And obviously with the pandemic and social distancing, that became impossible because you couldn't do the volumes. Newcastle could not do those volumes in the same way. One good dividend from that has been actually in terms of the implementation of Tele Dermatology. And so now all GP practices in Northumberland, not just in Northumberland, but actually region-wide, now take a photograph using something called a dermoscope, which is a high-quality photograph of a lesion, and that is now attached to the referral. That has therefore allowed the dermatology departments to reconfigure how they do things. And so now, well, the skin pathway, particularly for melanoma, patients are being seen well within the 2-week standard when they're being referred by their GP, or because actually the consultants and specialists are getting high quality images of those skin lesions. In terms of the pandemic, in terms of general practice, I think there's a few things to say. Number one is we always encouraged practice to keep services running, particularly for cervical screening, because of the benefits and the way it can pick up cancer very early. And we also identified some funding last year, which we gave to all practices to help them catch up on any cervical screening that was outstanding, with additional funding for those areas, particular areas where they're outlying on their performance, to try and encourage those practices to put on more clinics to do more screening. And it's also linked to the whole thing about GP access and about having more confidence for people to go in and see their GPs face to face, which is now happening, but is a process and is ongoing. And finally, early cancer diagnosis, a lot of quality improvement work in practices to look at safety netting. So GPs, nurse practitioners who've seen patients who are being referred, making sure that they do stick to the pathway and they are seen. And so a lot of work has been done on quality improvement from that point of view. Finally, the cancer recovery plan, the last 6 months, a lot of effort on, as you would expect, focusing on those individuals who are long waiters, people who are on the list have been waiting there for too long, and how to actually catch up with those individuals and get them seen and treated appropriately. I think at that point I'll hand over to Graham and let him just continue.
So I think the pandemic has obviously had a bit of an impact in terms of every service that we provide at Northumbria Healthcare, but with cancer in particular, we're seeing some interesting trends in terms of the way patients are coming through the system. So, for example, if you take the colorectal pathway, we've seen roughly 6,000 patients last year, but our diagnosis rate has stayed roughly the same at about 3.5% over the past 4 years. But if you take the haematology pathway, referrals have stayed pretty similar, pretty steady across the years. However, diagnosis rate's gone up from about 40% to 75%. So it's better that we're seeing patients and we're getting them treated quicker, but it is an interesting trend to sort of keep an eye on. I guess the biggest focus that we have at the moment nationally is changing the way we look at cancer pathways. So we're moving to something in October this year called 28 days faster diagnosis. And that's a bit of a change from the current rule, which is 2-week wait. So essentially when a patient comes in, it's expected if they see a GP, they are referred in and they are straight to test, or they see a consultant within the first 2 weeks of that referral. So that rule is actually going to go by October of this year. And the aim of that is to make sure that we're diagnosing patients quicker, because we could see a patient in 2 weeks just by sort of the patient coming in and seeing a CNS or seeing a consultant. But what we're really trying to do is get the patients diagnosed as quick as possible so that we can get them started on their treatment plan, or they can get on with their life without a diagnosis. So a lot of the work that we're doing at the moment, like Robin said, is around breast and skin. Skin's been really difficult, in particular over the past year. Obviously, there's been a huge change to the pathway, but we are starting to see some huge improvements with that now. I think the GP's getting used to how, the new method of sending pictures in, and it is better for patients because, it saves them coming in for that first appointment. We can already sort of have a look at the photos before the patient comes in, and when they have their first consultation, it's a lot quicker in terms of getting the actions done straight away. Breast as well. So breast, can be problematic at times in terms of there's various factors, but for example, consultant radiologists, there's not a lot of them in the country, and we're having to think of different ways now of how we support that service. So at the moment, we've just heavily invested in turning our own mammographers to help support the service, to make sure that all patients that are coming in a one-stop service are seen, diagnosed and treated as quick as possible. So colorectal services, this is probably our most challenging pathway at the moment. Like I said before, we've had about 6,000 referrals last year, which is quite a large number. But we've been doing lots of work, especially sort of when the pandemic started and during the pandemic, to make sure that this pathway is as smooth as possible for patients coming in. We've changed the way we do colonoscopies, so patients essentially go on straight to test, which helps with the 28-day faster diagnosis. And we've also increased the use of CT colonographies as well. So we're roughly doing about 50 CT colonographies a week, which when compared to other trusts in the region is far and above what they do. So some of the things that's been great with that is that the trust's been really proactive in terms of supporting that diagnostic, so much so that we're about to install a new CT scanner at North Tyneside. That's due to start being operational at the 1st of April, fingers crossed, and that'll essentially double the capacity across all of the services. So we have been looking at some other ways of again helping patients to be diagnosed quicker and making sure that, you know, like Robin said before, we're catching everyone that we can, and everyone, you know, who potentially might have a diagnosis is having the opportunity to be seen by the trust. So we've created a new pathway called the vague symptoms pathway, and that's for patients who have unexplained symptoms, weight loss, abdominal pain, things like that. And the main aim of that is to diagnose early you know, patients with cancer and make sure that outcomes are positive moving forward. So conversion rates are currently at about 8-10% of cancers. It's something that's just starting to come into place now. So we are trialling it. It's in April. It's supposed to go live full stop. So we're looking to have a positive impact on that and make sure that we're getting that cohort of patients seen and diagnosed as quick as possible. The NHS Gallery Research Trial. So that's a trial that's aimed at 50 to 77-year-olds with no cancer symptoms. It's basically a blood test, and it's taken by a mobile unit, which has been conducted in Teesside over the past few months and is due to come up here in the next couple of months. So again, the aim of that is to just try and diagnose patients as early as possible so that we can do something about the treatment plan and they're not presenting at the trust late with symptoms that makes the outcomes you know, not positive. So that's heading in the right direction and should have a positive impact. And we've also had another trial with lung patients. So obviously in this region, you know, we have a lot of sort of traditionally lung cancer is quite predominant within the region. So we started a trial with a pilot, with 5 practices in North Tyneside, basically getting patients in to come in and have a CT scan, which would sort of promote early diagnosis. So in 12 months, we've had 300 patients scanned, 10 lung cancers, so 3% pickup rate in keeping with larger studies, and 9 of those have had curative treatment, which is a positive outcome. Personalised care, so this is looking at the holistic approach with patients and making sure that we're having prehabilitation and we're providing enough information on health and wellbeing, signposting, empowering and improving patient outcomes. With that, we've also introduced stratified follow-up. So the Trust's recently invested £50,000 into a remote monitoring system, which will enable us to monitor patients and support them throughout the pathway once they are post-diagnosis and treatment. So some of the challenges that we've faced over the past couple of years with the pandemic, staffing's probably been the biggest issue, and that's across all services. Radiology is another service that I manage, and it's just been really difficult to make sure that, you know, when people have had COVID outbreaks, providing the right sort of resources has been really challenging. But, you know, we've adapted where we can and made changes and provided the best possible support that we can. It has had a slight increase in some of our diagnostic turnaround times. We were doing sort of, if you took CT, for example, request to performed was taken roughly about 6 days pre-pandemic. It's now taken about 8 days, so it is a couple of days extra on the patient's pathway, but still within what we would expect for the key milestones. Social distancing in all of our departments, particularly in oncology, that had a bit of an impact. So because we've had to reduce the number of chairs, that's impacted on at first on how we delivered a chemotherapy. But again, we've worked hard, expanded some of the units to make sure that we have enough chairs to be able to provide chemotherapy in a timely manner. In Oncology Services, so there's been some changes with treatment lengths, particularly on if you take lung patients. Previous to like 2 years, a patient would come in and they'd usually have the treatment within 6 weeks, and then we wouldn't see them again in oncology. And what's changed with that is now patients can have treatment up for 10 years. So that's sort of added additional patients into the system, which means we need more capacity to deliver. So that's been challenging, but the Trust has been very supportive in terms of driving things forward and invested heavily in the oncology service. So we've had roughly £600,000 invested in the past 6 months, and that's all due on staff. And that's had a huge impact, taking our wait from about 5 weeks for patients to receive chemotherapy down to about 10 days now, which is a really positive impact and obviously beneficial to the patients. We've also introduced new Cancer Navigator posts to support pathways. So essentially, they provide patients with more assurance and reduce anxiety because they have a person to contact when they're waiting for a scan or waiting for some communication for a consultant or a nurse. And like I said before, the second CT scanner is due to be installed in April this year, which will essentially double the capacity, helping patients to be seen in a much quicker time frame. So just in summary, I think work's ongoing to monitor all cancer pathways. Everything that we're moving towards with 28 days faster diagnosis is essentially a positive step. Some of the work that we've done with that is around introducing one-stop clinics. We have that in breast, but we're now introducing it in urology. We're also introducing it in gynecology as well. So essentially what that means is a patient comes in, and opposed to having 3 different appointments where you would see a consultant, go home, have your investigation, go home, and then see a consultant or a nurse again. The patient comes in, it's one day, see a consultant, have an investigation, see the consultant again, which is much better for the patient because it helps them to sort of deal with the diagnosis if they have one, and we can make a plan and move forward and get them treated as soon as possible. We're investing heavily into the pathways just to make sure that we are on top of this 28 days faster diagnosis, and that's across all specialities, all modalities, increasing surgical capacity, increasing oncology capacity and radiology capacity to make sure that pathways are as smooth as possible.
And then just finally, raising the whole issue about cancer awareness. I mean, this all starts before the pathway as well. It has to start in our communities in terms of raising awareness through the local campaigns, national campaigns. We have an individual at the CCG who has been going into businesses and reinforcing health messages into factories, into men with sheds. Just getting out there and just trying to engage people to say, look, it's really valuable that if you've got a concern, to seek medical help. So that's really all what we wanted to say. So thank you.
Okay, thank you for that. Have you got any questions at all? Wendy Patterson.
Hello there. Thank you, Chair. I'm just interested in these blood tests for people between a certain age. Can you tell us a little bit more about that? I mean, will people be contacted to attend this mobile unit in a similar way to, say, mammograms, that kind of thing? Is it an optional thing? I presume it would be. And how successful has it been in Middlesbrough?
So the trial itself has came from America, and that's where the whole gallery trial originally started, and it was rolled out in Teesside, I think about 6 months ago. So far, the pickup rate's been in keeping with what's been seen in other areas, and it is having a positive impact. I think, again, the pickup rate's between sort of 3 and 4%. I'm not too sure on the actual details of how they're rolling it out and in terms of the cohorts that they're attracting to the trial, but I believe that it's based in tandem with working with GP practices to sort of highlight any patients that they think would be suitable for the trial, and then to offer them opportunity to come and attend once the bus is up here, and then to move forward with that from there.
Right, thank you very much.
Any more? Claire.
I think just to add to that, Wendy, I think you can also dial, I think there is a website that you can go on to and fill a form in, and you can get called as part of that process too, but we can probably send you the link to the website.
Right, I think it would be very popular.
Yeah.
Okay, any further questions? I can't see any, so thank you very much for that report, and thanks for your time, and very informative, and all the best with everything. Thank you. Our next item on the agenda is indeed, I'll go back to, so I'm reading the right thing. It's Northumberland Combined Authority Wellbeing Framework, Northumberland approach. This is a report by Sarah Macmillan. Yeah, that's quite right.
Okay, thanks, Chair. Morning, everybody. I'm Sarah Macmillan, Assistant Director of Policy at the County Council. I'm going to talk to you today about a piece of work that we've been involved in as a council with the North of Tyne Combined Authority, the Wellbeing Framework. Now, let me just see if I've got the clicker right. There we go. So really what I'm going to cover today is to brief the board on that bit of work that we've been involved in that's resulted in a wellbeing framework being produced, seek the board's endorsement of that framework and also some of the areas we're suggesting for implementing the framework across the County Council, and then importantly asking the board if there are any views from the board about how they might wish to be involved in seeing the framework being taken forward. So in terms of a bit of background, why consider a wellbeing framework? Wellbeing frameworks have been developed by national governments broadly, and it helps the government understand really what matters to people in terms of their own well-being. And as part of that, it then helps the government and policymakers think through those important issues and look at them as connected issues rather than seeing things in isolation, which is as you, most of you will be aware, is often what happens. In terms of North of Tyne looking at this, it was very much in the context of the recovery from the pandemic. So in thinking through that recovery, what does that look like for the region? Wellbeing really ought to be right at the heart of that recovery. And it very much supports North of Tyne's inclusive economy vision as well, which is right at the heart of the devolution deal and the combined authority. So by taking forward this work, North of Tyne, we understand are the first combined authority in the country to look at this. So we're right at the forefront of that thinking, and there's been quite a bit of interest from other combined authorities in asking what we've been doing on this. So we got to the framework through a roundtable approach. This really came from an event that happened back in December 2020. North of Tyne worked with the Carnegie Trust and had an event which was really around exploring wellbeing in North of Tyne. And as a result of that, the advice from Carnegie, who developed these sorts of frameworks with other governments and with other partners, suggested a roundtable method, which was essentially selecting 12 specialists from across a whole host of areas to come together and really challenge and support and develop that framework. That roundtable was chaired by me and by Professor Mark Shuck-Smith from Newcastle University. And really the role of that roundtable was to gather the views of citizens, of groups of experts in the area, so that could form the evidence base from which the framework was then developed. And over that period of, it was over around 6 months, a lot of work over 6 months, the North of Tyne's Inclusive Economy Board provided the governance and oversight of the process. So it's important to say that one of the things the Roundtable decided to do quite early on in their discussions was to use a model that Carnegie Trust have developed. They call it their SEED model, which is social, economic, environmental and democratic wellbeing. And a lot of the work that Carnegie have done over the years has resulted in this approach that they've developed. And it really develops, or really sort of identifies rather, the key domains that are important for an individual's well-being. So the Roundtable decided to use that quite early on to then inform their approach and give them a framework, I suppose, to base a lot of the discussions and evidence gathering on. And that evidence gathering process took the form of various different stages. It was a very structured approach to gathering the evidence, but also very varied. So we heard from lots of different people. There was a policy literature review that was carried out where we looked over international evidence, but also linked that back to key regional documentation, key regional strategies. There was a call for evidence that was open for 8 weeks. And a number of partners, including a number of partners in this room today, responded to that consultation. We also took forward something that I've not done in anything that I've done before, but it was a really useful exercise where we wanted to hear from individuals who might not necessarily be aware of, never mind respond to a call for evidence or a consultation. So we worked with community-led VCS organisations rather across the patch and provided small grants, which then enabled them to facilitate discussions with their communities and with their groups. And that really allowed us to hear from people who we might not otherwise have heard from in terms of what was important for their well-being. And then the final step was a Yougov survey we commissioned, and that was over 1,700 residents right across the North Tyne area, a representative sample, and again, that kind of scale of response around what was important for individuals' well-being. How they felt about that, how they would prioritise those issues in terms of their well-being. That was all of that evidence was then used by the round table to come up with 10 wellbeing outcomes, and they map right across that seed model, so right across social, economic, environmental and democratic. And then we worked with the Centre for Thriving Places to develop a set of indicators that sit below those 10 outcomes. So the wellbeing framework is essentially three things. There's the vision, which is the North of Tyne Inclusive Economy vision, and then there are the 10 wellbeing outcomes. Apologies, that slide's got incredibly small writing on it, but the report is with your pack, so hopefully you've had a chance to see that. And then those 10 outcome statements are underpinned by the 52 indicators that we worked with the Centre for Thriving Places on. And they're based on regional, national, local data sets that are available and will allow us to then track progress towards those 10 outcomes. They include things that you would expect, like productivity, number of children living in poverty, health life expectancy, but they've also included in it a number of things that may not have been included in these sorts of things before, but respond directly to what we heard from the consultations. So things like litter, in terms of how people feel about the places in which they live, and also things like participation, local decision making, and how they feel part of that process. So as I said, over time, because that's a data set that is available, we can monitor that over time and monitor the progress towards those 10 outcome statements. So in terms of implementing the framework, the North of Tyne Combined Authority Cabinet, which is made up of the leaders and deputy leaders of Northumberland, County Council, Newcastle, City Council and North Tyneside Council, they endorsed the Roundtable's report and the framework at their January meeting. And North of Tyne colleagues are starting to think through how they will promote the framework and how they will implement it. They have decided that they will embed it into their decision-making processes and also, importantly, promote it and communicate the outcomes of that, because they are taking their role as a convener, and this is very important. North of Tyne organisationally is quite a small authority, but it has a lot of influence and a role in convening other partners. So it will be promoted to other partners to see how they wish to take forward the framework. North of Tyne will also be responsible for regularly monitoring the progress to the 10 outcomes. So those indicators that we talked about, that will be embedded into their data team. And then they've committed to regularly update the Inclusive Economy Board, but also Cabinet were very clear that they wanted oversight back to Cabinet level, so there'll be reports back to the Cabinet as well. And in terms of Northumberland County Council, we are starting to think through how best we can take forward the framework, how that fits with our own policies and strategies. It very much supports a number of the County Council priorities, and also I hope the board would agree as well, the joint health and wellbeing strategy. We're proposing to take it forward. Firstly, what we're going to do is take it to the Health Inequality Summit. I know that has been mentioned by a number of people today. That will be a really important piece to consider in those discussions with partners at the summit, you know, it will be useful to consider the framework and any actions I think that come out of the summit. We're also going to incorporate it into our health and all policies approach, and it supports a number of the objectives of that, including developing a tool which will just help across the organisation for individuals, officers to think about that framework as they develop policies before they're taken forward into the decision-making processes. And then finally, what we'll do if the board agree is to keep the Health and Wellbeing Board up to date with how the framework's been implemented across the region and across the county, and continue to work with the board as well on how that's implemented. So finally, Chair, in terms of the recommendations, just asking Health and Wellbeing Board to endorse the framework and the proposed areas for implementation by the County Council, but also happy to hear any views from members of the board, Chair, on how they might want to be involved in taking forward the framework. Thanks.
Okay, has anyone got anything they wish to say on that? Claire?
Thank you, that was a really helpful update. I'm just wondering how this will be brought into the local system transformation board in light of, I think they may have met yesterday actually in place-based arrangements, and just trying to join the dots on all of this.
Yeah, thanks, Chair. I'll come back in. I think that's a really good question, Claire, and it's a one that has occurred to me before as well. And actually, I think probably there are people in this room who are probably closer to the answer to that than I am. But I think it's something that we'll want to consider as those arrangements are developed and they go forward, because as far as I can see the developing arrangements, this fits, you know, very, very clearly with how that's going to move forward.
Okay, have we got any more questions, comments? No, I'm not seeing any. So what I will do is I'll go to the recommendation that we endorse Wellbeing Framework and proposed areas for its implementation in Northumberland. Do we endorse that? Yes, excellent. Okay, thank you. Thanks very much, very informative. And I go to the next item on the agenda I've got is IPC progress report, presentation from Siobhan Brown. I don't think Siobhan's here, is she?
It's me.
Okay, right, great.
What I was going to do is, can somebody zap for me? I think. I'm going to look at them on here because I struggle to read when it's so far away.
I think you'll be doing the Chris Whitty next slide, please, won't you?
I'll try my best. Right, okay. I am conscious that I am talking to a dwindling group of people, and I'm also conscious that we're 90 minutes into a meeting and you have absorbed so much information. There's been so much information on the slides today. So I do not intend to try and tell you everything about what's on every single slide here, okay? I shall try and put this into context. Interestingly, we have just heard from Health all about how to look at pathways for cancer, how to work with a partner in the system, how to think about the quality of what's being provided and how to change the pathways and work on that. That's CCG world, Clinical Commissioning Group world, okay? And a lot of our residents don't really know anything much about what a CCG does, and yet it is very much glue in the system in terms of using a finite resource for health, getting the best value for money you possibly can, but being sensitive to the needs of the population that you serve. When we talk about place, for me, that always means Northumberland. And in what we're talking about for this, we're talking about Northumberland when we talk about place. We've also then had a health and wellbeing report, or a wellbeing report, which is another part of the picture. And actually, Claire very rightly has said, well, hang on, how does that work into our system in Northumberland, and how do we make that part of what we do? Which is almost exactly why we're talking about rearranging our commissioning system. This is an update, and I got to the, where are we at? You've got that one. I'll go on mine. So where are we at with the rearrangements? We know that we have a clinical commissioning group with a statutory arrangement, a governing body which signs off the final decisions and monitors the quality of things going on in Northumberland. As of the 1st of July, that changes, and that statutory function will go to the ICB, the Integrated Care Board. So there is a change in governance coming that has to happen. And we have to work out how does our place work with that. And actually, we also have to realise that our place is not broken in any terms. And this rearrangement has to build on the strength of what we're doing in Northumberland. And we as a Health and Wellbeing Board have to make sure that we play into that rearrangement of the governance that will need to happen in Northumberland to make sure that it's right for the people of Northumberland. There is now a Chief Executive Officer in place, Sam Allen, and she is very much listening to what needs to happen in place to make this organisation functional and to get the right decisions made in the right place, most appropriate to the needs of the people in those areas. Okay, we will be moving to a shadow form in April, which is not long away at all. And there's a transition process going on, and we now have an operational framework being suggested, which is how we will work through this organisation of the ICS. And this is an engagement process about informing people and listening to what should and could happen. Next slide, please. So many bits of terminology which are really confusing. An integrated care partnership. From a strategic point of view, our ICS will have a big one. So Liam Donaldson did an awful lot of work with local authorities to try to work out what should happen over our huge footprint in the northeast and North Cumbria. We are huge compared to most other ICSs, and that has given us a set of problems or challenges which are not necessarily the same in all ICSs. But we've fallen on a pattern where we know we have ways of working, for example, north of Tyne, Gateshead, and we will continue to nurture those relationships which will work between local authorities. There are some things best done over those footprints, and we've just heard about the Wellbeing policy, which is a north of Tyne construct. So there will be some subgroupings of the ICP, but there needs to be a larger version which works directly with the ICB. So that's basically where we are with that at the minute. Place-based working and expectations. So we will still need to have a place, and it will still need to have its own set of governance and accountability, but actually it can be flexible to what's already occurring effectively in those places, but it may need to be fine-tuned, and we will need to look at representation on our different bodies to make sure that we've got the right people so that we are moving into a more integrated way of working than these decisions being made in isolation between the different partners. The ICB will have a job to make sure that the places are performing their functions correctly and according to the set of criteria that the ICB needs to achieve. Here's a list of all the different types of places that we've got. So if you look at Northumberland on this list, we have a system transformation board in Northumberland where currently our partners meet and discuss the threads of performance and some of the issues around certain pathways. We have a Health and Wellbeing Board, and there is work to be done about how the Health and Wellbeing Board interacts with System Transformation Board, which is the point that was just made over here about how we make the threads run through. This construct is really what came out as a national thing. It shows you how an integrated care board will exist alongside an integrated care partnership, but then it comes down to these places underneath, and on this one it drills more down into neighbourhoods. And we mustn't forget that Northumberland is a very big county with very different diverse communities within it. We therefore have these constructs around primary care networks, which is groupings of GP surgeries, and actually they need to be working much more around their neighbourhoods and the needs of those. And that comes down to listening to our populations, and it's all about voluntary sector contributions in those neighbourhoods and our mechanisms for making them represented. There are some guiding principles that we need to think about. So structures have to be effective, we have to have the right planning arrangements, but place-based working comes into this. It's much of what I've already said. on that slide. Financially, the overall pocket of money still has to be spent wisely. Where the decisions get made on that resource allocation will look slightly different in this. And interestingly, these 13 places in the 13 different CCGs, you can see they're one up. That's where the statutory function was in what the current level is. The ICB overall has the statutory approval at that level, but we will still expect a delegation of funding down to place so that we can make the right decisions for the people of Northumberland. Key questions for us. There's a number on there, but I think for me, the one in the middle highlighted in blue about pooling budgets and how we work jointly together and make decisions together about our individual resources to get the best out of the people, for the people of Northumberland. And then ultimately this bit about what place-based infrastructure would be required to support this, and can this only be delivered at place or across places. So for us, we have to make Northumberland work correctly for us. And I would challenge us to say our System Transformation Board needs a refresh in the light of the ICB governance arrangements to make sure that we have the right representation and the right leadership, and we know essentially who we are accountable to and how our operational officers are feeding into that. I shall stop. Claire was going to help me with this presentation in Siobhan's absence, and I'm happy to just hear if Claire wants to add to that at all.
No, I mean, the slides are hopefully, I know it's difficult to see them on the screen, but people will hopefully have a copy of the slides. I think the main thing is we need to get to a point where we are working collaboratively on a range of different things, both at a place-based level. You've already referred to what happens with the System Transformation Board in light of the clinical commissioning groups, the change in the infrastructure, but also on the Integrated Care Partnership Board. How do we co-produce that across the system so that it cannot be an NHS construct, it has to be a system construct, and there are plans being put forward to go out to local authorities and to request representation so we can collectively shape exactly what that looks like. So I think there's two things being set up here. There's the NHS Statutory Integrated Care Board, which has to be set up because of the clinical commissioning group responsibilities going into there, but with maintaining the place-based arrangements. But more broadly, how should the Integrated Care Partnership work across our North East and North Cumbria system? And there's a lot more work to be done on that. There's a huge amount of work collectively for us to do on that.
Okay, Wendy Patterson.
Thank you very much, both of you. Dr. Sayers, can I just ask you, I mean, this is huge, massive. Would it help us at this stage, and I know it's early, for the Chief Executive to attend the next Health and Wellbeing Board?
It's not for me to say how the Chief Executive organises. She has a huge job about understanding our area. At present, she's going through an engagement process. She did a roadshow to the CCG last week to meet the people of the CCG first. She's been very busy recruiting to the ICB to make sure that the people are in place to make that functional. And I think the next part of her job, I'm sure she understands, is to come and meet some people, but if you take into account that there are 13 different places and how to organise her time to do that, we can extend an invite, absolutely no problem with that, but I think it will be part of her plan. Maybe, I know Claire, you're involved with the engagement, so do you want to come back on that as well?
Yeah, it's definitely part of the plan to get round all of the Health and Wellbeing Boards. So Sam presented to Cumbria Health and Wellbeing Board last week. So she will get round. There's no doubt about it. But we need to make sure that actually Sam represents the central organisation really in that sense, and that it should not take over the place-based relationships and the importance of those place-based arrangements, because they're not going to change. And money will be devolved to place-based areas, and that's not going to change. So I think there's a bit of working out around all of this, but I think she will definitely get around to all of the areas. there is an emphasis on place and should remain an emphasis on place, but also local authorities have been involved in the JMEG development to where we are now with regards to those place-based arrangements, and it's making sure we get that representation too as the Integrated Care Partnership Board is developed too, and of course Sam will be involved in that work also.
It is incredibly complex, the whole thing, and I don't know whether she would be able to, if you like, give us some direction, but I would like us to issue an invitation.
And just to back Claire up on the point, I think there's the statutory bit that has to be done, and that has to be there, and it has to be safe, and it has to be effective, and that is really a priority because there's a time frame on that. The relationship and the ways of working is certainly something that can be developed over the next year and 18 months. So I don't think there is a rush to change the way that we relate to each other in place in any sense. In the short term, it's about making the ICP element of this and the integration and combining the well-being element and all of those social determinants of health into the decision-making process.
I'm not too sure if anybody has read the Secretary of State's for Health speech this week on health reform. I'm happy to send it round. It may be helpful in that context as well, because I think if you think about what the System Transformation Board is doing around a range of different areas, it all fits, whether or not it's at the regional level or at a local level.
As I say, it's incredibly complex, very.
And one final thing. The summit, the Health Inequality Summit, actually informs our System Transformation Board too, and the work plans will need to align there. So that's certainly not being done in isolation to anything else which is going on in the health rearrangements at the minute.
Thank you. Thanks for the update about progress with this, very, very complex transformation. But just 4 quick observations, if I may. As has been mentioned by Graham, there'll have to be a closer liaison somehow between the Health and Wellbeing Board and the System Transformation Board. But I'm not sure where the Overview and Scrutiny Committee fits in with this. So I think that's part of the challenge. Another huge challenge, as has been mentioned, is in the last few months we've had all sorts of presentations about health inequalities and the wellbeing framework, what Northumbria is doing and so on. It will be an enormous challenge to try to simplify that very, very complex range of organisations, authorities, people who are trying to make things better. They're all well-meaning, well-intended, but it's to make sure there's no duplication, to make sure they complement one another without making it even more complicated, if you see what I mean. And I think there are 2 challenges within all of this, which will probably add to the complexity in a way. I think one is, we hear so much now about social determinants and the effects of housing, employment, education, etc. on health and well-being. I think unless that challenge is grasped to really involve social determinants in what is happening, I think that would be a retrograde step. I think we need to accept that challenge, even though it will add to the number of people involved in this. Because if the system doesn't, they'll be missing huge determinants of how well people are and how they live. And the final point, again, a challenge which hopefully will be grasped, is somehow, without adding the complexity, involving the public, the communities, in not necessarily decision-making, but in awareness and contributing to what is being decided on their behalf. I think public engagement, public communication, public involvement is difficult. But again, I think it's something to be seized now from the outset to make sure that decisions which are ultimately made, they do listen to what people are saying, because people can often say things which, on the scale of things, are not always included as priorities. So, just 4 quick observations from Healthwatch. Thank you.
Okay, thank you for that.
Can I just respond to that? I think there were really helpful observations, David. One of the key strategies, draft needs to be submitted by the end of May, is a people and community strategy. And that includes a lot of what you're talking around actually what are the key principles from a core involvement and engagement point of view. I think what's helpful as well is you'll know this, we've been working with some people in Healthwatch around obviously they are commissioned locally at a place-based level to provide the function that they provide, but also how does that fit at a regional level and how can we mobilise and share best practice at a regional level too. So we've secured some funding to help them really model that out and how that works. And likewise, there's been some funding secured for the voluntary sector with VON around how do they mobilise at a regional level too. So I think there are pockets of work happening, but there's more definitely that's needed to be done. And I think the more we understand how all of the questions that you've posed around how it all fits together, I think it'll allow us to have that broader conversation.
It's very, very difficult, but I think those fundamental principles need to be absorbed.
Thank you for that those comments. Anyone else? I think we're done with that. I don't think we're just noting that, aren't we? There's nothing to decide there. So I'll go to the next point on the agenda, which is Health and Wellbeing Forward Plan 165 to 172, just to note that. And then urgent business, I have no urgent business, and I've got date of the next meeting, Thursday the 14th of April 2022, and it will be in this room here, I think, again. I don't think we'll quite be in the chamber by then, but we won't be far off, so I'm told. So with that, I'll close the meeting. Thank you very much, everyone, for attending.